wanted to do some follow-up to the line of questioning that Senator Street had engaged with you on ASAM, and that having that tool to measure. And I have to agree with his sentiments. A couple of things that I just wasn't clear on in that conversation, but when exactly are providers going to be able to see the standards that they are going to be measured against? I didn't know if, I don't recall that you shared a timeline with him.
Yeah, so we get this question a lot, and the answer is the providers already know the standards because the standards are exactly what's in the ASAM book. So the mystery behind this monitoring tool is not a mystery about what the providers will be asked. That's very clear. It's exactly what's in the book. The reason that the tool is taking a little bit of time to work on is, as Deputy Secretary DiDomenico alluded to, we're really trying to reduce the administrative burden for providers. So we're combining the tools that previously had been used by the single county authority and the tool that had been used by the managed care organizations, and creating one tool where they have shared responsibility for performing that monitoring. So the challenge is taking a look at the tool and figuring out which pieces of the tool and the monitoring will be the responsibility of which entity, so that providers don't receive 2 monitoring visits. They get monitored once on those criteria. So there's really no mystery about what's going to be monitored for. It's a matter of which entity is going to be performing that function.
And you're working with the consulting company, Mercer, to execute that work?
Yes, Mercer is on contract with the Department of Human Services, so yes.
Okay, so when we ask about a timeline, do you have an expectation of when that work with Mercer will conclude?
So significant portions of that work are completed. As I said, we actually showed a number of the folks who will be participating in this work, that tool yesterday on a Teams call. The plan is that we will be starting the monitoring, the official monitoring, with those providers before the end of the fiscal year. Okay. So we're really going to be making contracts with those entities to come out and be doing that work by that period of time. I'll just add one really important piece. I believe there's some sense among some of the providers that we're not showing them something or telling them something. I mean, the tool is really the mechanism by which we'll gather the data, as opposed to containing anything that they don't already know. I mean, so they know what the criteria are. We've talked about it on multiple conference calls with them, multiple training events, multiple technical assistance meetings with individual providers. And we've even previewed that with some of our levels of care in terms of actually working through a process for 2 levels of care, the levels that we call partial hospitalization and the level that we call medically monitored inpatient residential. We have worked through that with those providers individually to separately align them. So, we have about 55 partial hospitalization providers. We have 11 medically monitored providers who we've not had in Pennsylvania in the past. Those are brand new providers, and have about 4 more in the queue to work with them around that. So, we're already working with many of those providers that are those new and very enhanced levels of care in this transition to really make sure that what information we're gathering is really available easily.
Thank you. Just one last question on this issue. So how will the department maintain a role in the monitoring process rather than handing it off completely to the behavioral health MCOs? How do you envision that working?
Yeah, that's a great question, and this is a perfect example of the collaboration between departments that Senator Brown will painfully remember. We had lots of hearings about consolidating agencies and the benefits of being able to work together, and this is one of those benefits that we talked about in terms of forming closer relationships within state government. So this has been a process that both DDAP and DHS, particularly the Office of Mental Health and Substance Abuse Services, have worked in lockstep to develop. So The monitoring tool itself and the discussions around who will perform which pieces of the monitoring has been a joint decision between us. And that's relevant because DDAP has oversight of the single county authorities, and DHS has oversight over those managed care organizations. So it is important that our two agencies remain closely aligned in terms of what we expect from them, what the tool looks like, and how the responsibilities are divvied out. And then each of our respective agencies will have to ensure that their partners are adhering to their end of the deal.
Very good. So you spoke a little bit earlier about Atlas, and over the last year or so, we've been hearing a lot from our constituents about that need to know more about the drug and alcohol providers that they are entrusting their loved ones to, and the lack of transparency about the facilities, and which ones may have failed DDAP or DHS inspections, and which ones had serious safety concerns in the past. And you are talking about implementing this new tool, Atlas, and I think it stands for Addiction Treatment Locator Assessment and Standards Platform.
You got it.
You talked a little bit about how you're creating that tool. What is the price tag on this contract with Shatterproof?
Good question. And give me 1 second to get to it here in my notes. So the contract amount was for $1.1 million, and that was a maximum amount, and I'll come back to that explanation in just a second. And it spans a 3-year period of time. So the budget for year one was about $370-some thousand, which included all of the work to establish Pennsylvania's providers in this tool. So it included a lot of upfront work in terms of delivering surveys to providers with unique logins for them to go into the system and complete the survey data. It includes Shatterproof doing some cleansing of that data and potential follow-up with providers where there's missing information or information that doesn't seem to match with what should have been submitted, and those kinds of things, as well as official rollouts, trainings, communications. So the cost in year one we knew would be more significant than the ongoing costs. We don't yet know what the ongoing cost will be, and the reason for that is as Atlas continues to expand to additional states, that cost will decline because the cost for them maintaining the system will be spread over a larger number of states. So currently there were 6 states in the initial pilot that I listed earlier. Aside from Pennsylvania, as part of a second rollout is also included New Jersey, Florida, Oklahoma, and California. So, as the years progress and additional states keep rolling into the system, those costs will be declining. So the contract was set up with a maximum amount. That doesn't mean that will be the amount that we end up paying.
Do you expect there to be ongoing expenses after year 3 of this contract for the Commonwealth, or do you expect that fees will be paid by providers to maintain this tool?
I do expect there will be some ongoing cost, just because there is a cost to maintain a data system and a data set. And what happens with this system is each year providers will get the opportunity to update their information in the system. So, there's also a bit of a responsibility there for Shatterproof to cleanse those changes to the data. Also an opportunity each year for new providers to opt in to the survey tool. So here in Pennsylvania, we did not mandate the use of this tool. We currently have over 65% of our providers who are opting to utilize it. And part of that is because our larger providers particularly operate in states that are already using Atlas. So for them, it really makes a whole lot of sense to continue to fill out the surveys for all the states that they operate in. But we do expect an ongoing cost. We don't expect to pass that cost on to providers.
And one last question. Will you, or do you anticipate utilizing Atlas as a tool to measure provider performance?
Great question. When Atlas was initially developed, it was marketed as an opportunity to be a treatment locator as well as sort of a performance outcome measurement system. When they started piloting this with the initial first 6 states, those states said, this is going to be way too much for us at one time. It's going to be difficult to gather the data. It's going to be too complicated and confusing. So they really set aside that component and focused on the locator piece, which is what we are implementing, the locator piece. They are now beginning discussions with those initial first 6 states to see if any of them are interested in using it for some kind of quality measurement. And really what they'd be focused on is using Medicaid data specifically, and adding to that, if they could get any private insurance data, they would accept it as well, on just a handful of kind of key measures in terms of length of engagement and those kinds of things. So it's really, really, really early in those discussions. It would not be a requirement for any state to implement that functionality, but it would be something for Pennsylvania to look at. If they do that successfully and other states find it really helpful, it's certainly something we could pursue, but at this time we don't have plans to do that.
Thank you very much, Secretary Smith. Thank you, Mr. Chairman.